Okay, so hello and a very warm welcome to this NOI group clinical discussion. My name is Joanna Taylor and I am Director of NOI Group Europe. And I am joined this afternoon by NOI Group teacher and my very good friend, Dr. Ben Davies. Hi, Ben, and welcome.
Hello, hi everybody.
So, welcome back, Ben. For those who missed our previous sessions, Ben is an advanced practice physiotherapist specializing in persistent pain and rheumatology. I'm not going to try and say that really difficult word. I'll leave you to say that, Ben. He brings over 15 years of experience teaching explain pain and a gift for making the complex neuroscience accessible and immediately applicable. So, Ben, it's so great to have you back. Would you just remind everybody a little bit about what you're doing currently professionally?
Yeah, I'm a full-time physiotherapist in the NHS. I work in Bath in the southwest of the UK. I run the only residential program for axial spondyloarthritis, which is a spinal condition characterized by fusion. The oldest hospital in the UK based in Bath, the Royal National Hospital for Rheumatic Diseases, and they've run a rehab course for AS for around 50 years, which is my pleasure to run now, along with medics and nurses and occupational therapists and psychologists and podiatrists.
Thank you. That's fantastic. That is the word, isn't it? Go on, say it again.
Axial spondyloarthritis,
I can never say that.
AXPAR for the
Thanks. Yeah,
initiators.
that would be easier. Thanks very much. Okay, so thanks, Ben. These sessions are all about giving you a taste of explain pain and how to practically use it in the clinic. Some of you will have already done an explain pain course, and for those of you that have, these sessions will both reinforce what you've already learned. But if you are new to explain pain, this will give you a little taste of what to expect on the core course. Ben has an upcoming 2-day explain pain course in December on the 4th and 5th. And for anybody interested in attending, we'll give you some more details about that at the end of the session. So if you're not interested, you can just jump off. But if you'd like to hear more about it, then just hang around till the end and we'll give you some more information about that. Just a couple of things to mention before we get going. Ben's going to be talking for about 20-25 minutes. If you have any questions, please pop them in the Q&A or in the chat, and we'll get to as many of them as we can. If you want to watch the recording for the session, you can access it in the Clinical Discussion YouTube channel, the links to which are at the top of the chat. And I'll just drop that in there again now. And we also have a Clinical Discussion Facebook group. If anybody would like to join that, that is managed largely by David Bolton, who I'm not sure if he's on the call today, but he's a absolutely superb clinician, highly experienced NOI group instructor and ambassador. And he is always in there sharing his wisdom and supporting people with their questions. So do go in and join that group if you're not already a member. It's fantastic. So today we're going to be talking about when your body gets stuck on high alert, understanding chronic stress and pain. So could you tell us briefly, Ben, what you're going to cover today?
We're going to think about how we all, as humans, how we respond to stress. And I want to kind of make a distinction of the kind of stress that we're talking about. But how do we respond when it's a short-term stress? How does that change, perhaps, if it's a long-term stress? Some stresses we can get away from, some stresses we can't. And we want to think about how we pick that up in clinic and how we might help somebody, I suppose, bring that stress down and down-regulate their system.
Fantastic, thank you. So let's get started with the thought experiment that you use on the Explain Pain course. Can you walk us through what happens in the body when we feel threatened?
So we could do it almost now. People are on the call. We've got 181 people on the call. You know, you can do this as a thought experiment. You can write a few things down, but can you write down 3 things that happen, 3 things that you notice when you're in a dangerous situation, such as a near miss on the motorway? You're driving down the motorway, down the freeway, down a fast road, and you have a near miss. What happens in your system? What happens in your body? Give that some thought for 30 seconds.
Mm, okay, so super interesting.
You
Nice.
might think, which systems get switched on?
Mm.
What gets kind of prioritized? What do you need to do in that situation? Which systems might get switched
Mm.
off? And
Okay.
so, this is a thought experiment, very much thinking about acute stress. And I suppose my distinction of stress is, by stress on the course, we don't mean that idea then when people say, "Man, I'm really stressed." What we mean is stress in terms of a biological shift. Stress means your response to something that is trying to push your
Mm.
system in one way. So dehydration is a stress. If you're not drinking enough and you're sweating lots out and you're producing urine, that's a stress. Your body's becoming dehydrated, and you will do stuff physiologically. You'll hoard water. You'll do things voluntarily. You'll go and get a
Mm.
drink. You'll do things, in order to counter that stress. Stress might be environmental temperature. If it's very cold where you are, you will involuntarily shiver to push you against the stress of the cold. You might voluntarily put clothes on to warm yourself up. You might
Mm.
do something that society allows you to do, which is turn the heating on. So there's different layers of how you respond to that stress. So stress that we're talking about in this conversation, Joe, is when something is pushing your body in one direction, and how are you sort of pushing against it? So
Yeah.
let's think, what happens with that car driving, near miss on the motorway? You've probably tightened up. You've probably become somewhat braced. You might well be guarding in case you've been injured. You might well be very cognitively alert. You might be thinking, has anyone been
Mm.
hurt? How do I deal with this? What's going on? Has my car been injured? Has my car been damaged? You may well have a surge of adrenaline.
Mm.
And what
That's really
happens when
good.
we have a surge of adrenaline? You might well have energy that you didn't realize you had. You might have been tired at the end of the day, but that surge of adrenaline flares you up, wakes you up, allows you to do what you need to do. But other systems get switched off. The drive to sleep is probably going to be switched off.
Mm.
The drive to procreate or be intimate is probably going to be switched off. The drive to be social and fun loving is going to be sort of suppressed, because you've got to do certain things in that situation to survive.
Mm.
And that's the thought experiment that we think about for acute stress or acute threat. But what
Mm.
if something like a car accident, or a near miss, you get away from it. That finishes, that period of life finishes. You step off the roller coaster. You get away from the barking dog. But what happens if you can't get away from those situations?
Mm.
What if you can't step off the metaphorical roller coaster? What if you can't get away from the dog that's chasing you around the park? What if you've got things in life that are ongoingly stressful, and health conditions, pain, fatigue,
Mm.
low mood, worry? How those things are impacting on your role in life? Is it affecting you as a parent? Now I can't parent in the way that I want to. That's a stress. I can't be the partner that I want to be. Time off work. I'm not being the employee I want to be. Not being part of my community in the way that I want to be. Those become stresses.
Yeah. It's an important distinction, isn't it? So between the acute threat situation and then this sort of drip feed effect that you're talking about here.
Maybe there's two other words. Is it an adaptive response? Is it a helpful response? If you're being
Mm.
chased by a tiger, if you're being in a near miss car accident, then all of that adrenaline cascade, the cortisol cascade, the fight flight response that comes from those neurochemicals is absolutely adaptive.
Mm.
But maladaptive, what if something's not so helpful? What if this response that you're now having through this drip feed of perhaps adrenaline in the background, cortisol in the background, a hormone that is a sort of slow burn stress hormone? What if that drip feed is now maladaptive? It's creating physiological responses,
Mm.
conscious responses, maybe social responses that now they're not so helpful. In fact, they may even be literally unhelpful.
Mm. What happens when somebody can't get away from that kind of drip feed stress?
So one way to think about it is, I just mentioned cortisol. cortisol is released by glands above your
Mm.
kidneys, and it has this slow burn effect as part of the fight-flight response. But cortisol, we will know, people who might prescribe or look at people's medications, prednisolone's a steroid. And we know there are long consequences of steroid use long term, things like bone density loss, immune dysregulation, weight gain, mood changes,
Mm.
sleep disruption. And prednisolone that we give people as tablets is the analog of cortisol that your body produces. Prednisolone is the medical way of giving you that prednisolone, giving you that cortisol effect. Short-term cortisol, short-term prednisolone is absolutely fine. But when there's that drip feed, there are known, I suppose, side effects of prednisolone and
Mm.
therefore of cortisol, side effects of those hormones being released, drip fed in the background, that become sensitizers for pain, that become inhibitors of good sleep, that affect your immune system so you may not heal in the way or repair in the way that you would be without those stresses. And your mood will change.
Mm.
You're going to be worried, you're going to be frustrated, you're not going to be the person that you're expecting to be. And then we set up this cyclical situation, unfortunately, where because of the symptoms I'm feeling, pain is the driving experience, becomes a stress in and of itself. And we can layer
Yeah.
that up as well. When people go to, they have a pain problem, they come to clinicians and we struggle to explain it. We MRI scan people and we find no clear cause for this pain. Then
Mm.
that uncertainty is also something that's feeding into the overall stress that somebody's experiencing.
So does pain become one of the protective outputs?
So we've talked on pain. Pain is there to make you learn from what you're doing and probably learn not to do it again. Fatigue is an output. Fatigue is a
Mm.
sort of setting of the system to either give you energy or not give you energy. Mood is an output of the system. Do I want to be protected and hide in the cave? Because in the cave is safe, and that's really a metaphor for depression. Do I
Mm.
want to be on high alert, like a meerkat in the desert, looking out for everything? That's a sort of metaphor for anxiety.
Mm.
We'll have
So,
we'll have
sorry, no, go on, carry on.
well, and then we might have sort of social changes. How
Mm.
those behavioural mood changes become social changes. We might not want to meet up with friends in the same way because those friends want to go for a beer in a fairly busy restaurant or bar, and I can't cope with that, so I won't. I won't take that invite. I'll stay home. Those people want to go for a 5 mile walk, my friends, but I can only manage 1 mile walk. So our social world might well begin to shrink.
Is
So
this
that
where
biopsychosocial impact of stress is profound.
is this where DIMS and SIMS come into play? Could you just explain what DIMS and SIMS are and
Yeah.
practically what they look like with when working with patients?
So I think the protectometer, which is a sort of NOI product, and this balance between danger in me, dim,
Mm.
danger in me, threat to me, stress to me. I mean, I think you can choose different words, but dim versus sim, safety in me. What are the factors that make you feel? And we all have factors in our lives that make us feel stressed, make us feel somewhat wound up. And we all have factors in our life, we'd hope, that are mitigators, that are sort of the other side of the coin, that calm us down and bring us down and ground us and make us feel at peace. And that sort of seesaw metaphor or weighing scales metaphor or yin yang metaphor in terms of light and
Mm.
dark, these are all ways of describing this balance that's required. Dims and sims, though, Joe, can come in uh, categories. What are the things that you might smell or see or taste that might put you on edge? I know that if I smell tequila, the smell of tequila, I get a feeling in my body of nauseousness. I haven't
Why is
drunk
that,
tequila.
Ben?
I haven't drunk tequila in 30 years for this reason. But that's a dim, that's a threat to me. My
Mm.
system's learned that threat is often associated with, being sick the next day and hungover. So I've learned to respond to that olfactory smell stimulus says don't have that. Maybe
Mm.
you've had, maybe you've had bad seafood somewhere, or you've had a bad Chinese takeaway from a certain restaurant, and so you don't go there anymore. Is it people who are the people in your lives, Joe, people on this call, who are the people in your lives that sort of, just put you on edge a little bit, just wind you up a little bit, make you feel less comfortable, may
Mm,
provoke, your stomach to flip or your sort of hairs to, or that tension through your shoulders.
mm,
But there are also people in your life where you feel absolutely calm and secure and supported and listened to, and all those close friends, dear loved ones. Those are people as a sort of domain of DIMS on one side and SIMS on the other side,
mm,
that we might want somebody to essentially take a bit of a step back from the symptoms that they've come to you with. Most people come to people on this call with pain as a predominantly driving symptom. That's why we seek healthcare. But sometimes we often want to get people to step back a bit and go, okay, what's going on here? What's going on in terms of my social life? What's going on in terms of work? What am I noticing? How my symptoms might fluctuate depending on
mm,
people, locations. When I go past that junction where I got hit by a car, where I go near that place where I was injured last year, years ago, I tighten up. But when I ride my bike, Joe, I came off my bike on a wintry day, and I came off my bike on some black ice. And even if I go through that hill midsummer now, it could be 20 degrees, I just brake a little bit on my bike. I
mm,
just slow up. I've learned, I've learned that in that place, once 10 years ago, I hit some ice and I had an accident. Even now, my body says, my system says, just slow up. So things like locations, but the flip side of that, where does somebody go to feel at peace? Is it the gym? Is it the beach? Is it the woods? Is it in their garden? Is it to church, mosque, synagogue? Is it to
mm.
the local crafts group? Where do you go? Who are you with? These things are all counterbalancers for the stress that we might be under.
Thanks, Ben. I was thinking about it like filling up a stress bucket, like
Yeah,
filling it up and emptying it. That's sort of a visual that I've found
we
useful with this.
absolutely use the stress bucket on the course, and there's a tap, and that's life stresses, because we've all got stresses, we've got stuff that happens,
Mm,
and we've all got a plug hole at the bottom of the bucket, and that plug hole keeps the stresses flowing out. It's how we all manage it. And sometimes either the tap opens a little bit more, or maybe the plug hole gets clogged a little bit
mm,
more. Sometimes a bit of both. And if the bucket is filling up, how does that manifest? It could be pain, it could be muscle tension, it could be feeling a bit more grouchy, it could be your stomach doing flips, it could be IBS flaring up, it could be libido affected, it could be sleep
mm,
quality down, it could be um, social isolation increasing, it could be change of dietary habits, a few more snacks, crisps, smoke a bit more, drink a bit more,
mm.
bit less exercise, bit less meditation, bit less relaxation.
Thanks, Ben. That's really helpful. We've got a question here which actually ties in really well to what I was going to come to next with you. So I just want to explore with you a bit about how we actually help patients to shift back from high alert to rest and digest, and a practical strategy. An example would be really useful. And Julia's put this sort of great scenario in the Q&A, which I'll just read out, and then maybe we could apply that to the question, a sort of practical example. So Julia said, intimate relationships bring up childhood attachment issues. You rely so much on your partner, so overreactions happen when you feel rejected, unseen, etc., even if a trigger is small. So someone could be in a non-abusive relationship, but have these reactions going on and end up feeling unsafe, only accepted if behaving good. So some approaches tackle this, EAET, but they are more therapy-ish. How in a pain neuroscience education, modern pain science framework, do you have this conversation? It's complex, but how would you broach something like this, Ben, which I think might just give us a practical strategy in terms of the DIMS and SIMS?
Into relationships, bring up childhood attachment issues. Yeah, I like that it's a complex concept, because I think that
Mm,
really opens up such a range of how somebody is. Um, so I'm going to be a non-abuse relationship, these reactions going on. Um, I think I guess uh, relationship counselling is not probably anybody's professional remit on this course, on this
Mm,
call. However, I think it's a really important a part of your patient to understand. And people can
mm,
have really supportive relationships, but when there is stress going on and sleep is not so great, or enjoyment or joy or humor or intimacy is affected, I
mm,
suppose as clinicians on this call, we can probably simply validate that. We can possibly have a role to say it's not surprising that your relationship is under some strain because you're not feeling like you want to go out on date night as a
mm,
man or a woman. That's irrespective. You're not wanting to have fun. You know that's going to have an impact on the relationship. Does that validate or provide enough sort of reassurance that this is not something separate to the reason that they've come in to see you as a clinician?
mm,
Now, whether you feel that's enough, whether the patient thinks that's enough, whether you feel actually that relationship challenge needs more support, and how does a clinician on this call link to talking therapies, relationship counselors, because there are other groups of people for whom communication and relationships is their bread and butter, to
mm,
have communication. But I suppose maybe it's that word, isn't it? It's communication. How does the patient communicate with their partner around their
mm.
family, their parents, their really close friends, around how this is affecting them? That honesty is probably really important. And do we as clinicians give them the validation that that experience is valid and not unusual?
Yeah, perfect. And relationships are such an important part of everybody's life, aren't they? Whether it be the primary partner or all relationships
Yeah.
will have and coming back to what you were saying before about DIMS and SIMS coming into categories. I guess relationships are one of those categories which you alluded to. People that make you feel good, people that make you feel on edge.
There was a sort of second part to your question around like a practical strategy,
Yes.
mindful time. I suppose a practical strategy. People they could think about how many relaxation techniques they have: mindfulness, meditation, breathing, square box breathing, piece of music. What piece of
Mm,
music, what imagery, where would you go that brings you, when I say down, that almost comes across, brings you calmness. That's what we're after, really. And
mm,
probably the most simple thing is breathing practice, whether that's a paying attention to your breath. You breathe in and you breathe out, and you focus on that feeling. You ask the person, you can do this practically. There's millions of YouTube videos that could, give you ways of doing this, but you ask the person to simply focus on their breath, the in breath, the out breath,
mm,
feel the cool, feel the chest rise. But we are all human, and our minds will wander and we will ruminate on the past. When your mind wanders, just come back to your breathing. When your mind wanders to the future, I've got to do this, I don't want to be late for that. My mind's wandered, come back to your breathing, the in and the out. I picked up a little phrase of just this. As you breathe in, just as you breathe out, this. A
mm,
little, what's the word? Verbal tag to kind of hold you with your breathing, hold you in the moment, to not be ruminating, to not be worrying, to be present. But, could you do that sat in the window looking out into your garden? Could you do that sat in the garden?
mm,
Could you do that, sat in the headland looking at the waves? Could you do that on the bus when it's a bit busy and things are a little bit more, challenging? That
mm.
simple thing of breathing for many people can be very calming, because it's the opposite. What do we do if we're stressed? We tend to breath hold or breathe shallower. So again, it's sort of the opposite idea. How do we just
Yeah. Very practical, small things. And one of the things that I do notice, Ben, about your courses is that you provide hundreds and hundreds of small examples, and it gives people a just a toolkit, but hundreds of little strategies that people can implement. I'm going to ask Marin's question first, and then Eugenie, I'm going to come back to yours because Marin's fits in really well here. Um, do you give patients homework to find out their DIMS and SIMS? Where is the border to not come too much into psychotherapy? So, one, do you give people homework in relation to their DIMS and SIMS, and how do you navigate your way through the boundary of your your practice?
I think, I mean, on the course, we almost usually this is like a coffee break, bit of homework on the course, or a lunchtime bit of break. We've introduced the protectometer, and in the resources that come with the course, there's a table that is this protectometer, and I would say, look, just across coffee, across lunch, put in these categories. There's 7 of them, I think. Put in the things that you as a person, the places you want to go, the things you like to do, the smells that you like, the people that you like to be with. Do that for yourself. I mean, that could be some
Mm,
homework. And I don't feel it blurs into psychotherapy. What I feel it gives license to is we are, and healthcare clinicians are really uh, um, guilty of this, is that we only focus on the dim side of the equation. You come to see me as a physio. What have you done? What's made it worse? You know, what's the injury that's gone on here? We don't focus enough on what are you doing when you're well? Because I think when we're, and remember, my clinical caseload is always people with a lifelong rheumatology condition, and this
mm,
condition fluctuates. And so clinicians are really good at asking, why have you got worse? We're not very good at asking, what were you doing when life was good?
yeah.
Because essentially, I want you to do more of the stuff you were probably doing anyway when life was good, like regular exercise and a healthy diet and good sleep hygiene and regular yoga and stretches. And, you know, you had a job that was good, and maybe your kids were in a good phase in their lives, but do more of that.
Mm.
But I think
You,
when life is good, we forget the fact that we're doing those sort of well-being, stress management behaviors because life's good. So you know,
mm,
you don't think of it as active management. And I
yeah.
mean this for me, Joe. I might mean this for you. You know, when life is good, you sort of forget that you're doing this stuff that keeps life good.
Mm, mm.
So I'm
That,
to Maren's question. I don't think it becomes psychotherapy. It just wants people to kind of just again big picture, but what are the factors in my life that are grounding, relaxing, anti-stress, pro-relaxation? Which word
mm.
feels right to you guys, to you
Do you
individually?
model this in the course then? So the DIMS and SIMS thing, you go through the DIMS and SIMS and how to use them for your patients in the course. Is that correct, Ben?
Yeah, we do. Absolutely. Absolutely.
Yeah,
And you know, there's such a range of communication as to how you inquire about these things and
yeah.
how you know, you as a clinician, someone says, well, I feel really good when when I see my when I go to church. What is going to church? Is it the habit? Is it the religion? Is it the people you see in church? Is it the smell of that old building or the incense? You know, there's like, sometimes we want to pull apart what somebody says.
Mm,
There's lots of features in there that might be for that person quite sim producing. Going to church, going to a religious place is sort of, there's a lot of under sub sims, little things. Okay,
mm,
where else do you see those people? How else can you get that feeling?
mm,
What is it about that example? It's a bit of a higher level sim. Can we understand what's going on underneath it?
amazing. That's brilliant. Thank you. Um, I'm just gonna we're gonna do Eugenie's question and then we're gonna start to wrap up. But Eugenie says that Lisa Feldman Barrett explains that by labeling certain um, sensations differently, the sensations themselves can feel different. Research supports this idea. How can you use this knowledge when explaining persistent stress to patients?
Yeah, I think that's a really interesting point. How does anybody describe their internal private experiences of pain or fatigue or mood? Your ache is not my ache. Your pain is not my pain. So
Mm,
if you do, we get a little bit focused sometimes on only talking about pain. Could we talk about the niggle? How's that niggle? You know, how's that uh, sorry, my mind's gone somewhat blank. Can you almost relabel
mm,
the symptom that they're talking about, not in a dismissive way? And I think that's probably the the nuance. We're not trying to dismiss it. You're not feeling pain, you're feeling a niggle, but just like, let's use something that's a little bit less. Use a word that's a little bit less threatening. Use a word that's
Mm.
a little bit less sort of maybe emotionally laden. Maybe it's a novel word. So actually, I haven't really gotten it. Haven't got an expectation about what you're sort of questioning. So does that
Mm.
help shift somebody a little bit to be more open to trying to then change it with your advice that you'll be given as a clinician? Have I done that much? I'm just trying to think. Maybe a bit.
Interesting question.
Called the pain in his shoulder a potato. Yeah, just point in the chat. I think I worked with a clinician who had breast cancer and a collapsed hip, and Trish would change her hip pain to be molten chocolate. It's really unpleasant pain. She'd sit in these
Yeah.
pain management groups with this unpleasant, excruciating pain in her own hip, never mention it to the clients in the group, but she would say to us as her colleagues, she'd just change her stance to that pain, away from pain. She'd label it or talk about it or visualize it as a pot of molten chocolate, and she found that helpful.
Fantastic, Ben. Thank you. Once again, the session is just studded and jam-packed with you really useful, really practical ideas and suggestions. So we're gonna wrap up there. If there was one thing for people to take away from today's session, what would that be?
Um, think broadly. I like that
Mm.
stress bucket analogy. This is biopsychosocial thinking, really. It's to think and inquire inquisitively around all of, somebody's life, so that you've got a real understanding of the stuff that is, on one side pushing towards this response, and that response might well be pain, fatigue, gut upsets, sleep disturbance. How do you then help them change those factors that are changeable? Recognizing, if you have aging parents who need support, that's not a factor that you can change
Mm.
easily. So job insecurity, that's not an easy thing to change, but it's sort of a contributor too. So then focus on change what you can change
Mm.
and manage what you can't change.
Thank you. Absolutely fantastic. I just want to give another little shout out to David Bolton because I see that he just arrived in the chat. Thanks for joining us, David. It's fantastic to have you here. It's David that is the manager in the clinical discussion group. So just jump in there. It's absolutely brilliant. David is fantastic. He writes some fantastic content in there, sharing his, well, I'm not even going to say it, David, but many years of professional experience. He's absolutely superb. So Ben and I are going to wrap up now, and we're just going to talk to you a little bit about Ben's about the Explain Pain course and how what we've talked about today fits into the broader course. So if anybody is interested in doing a deeper dive into these concepts and learning more from Ben's huge what do you call it, like bucket of clinical examples, and to really understand how to implement this stuff properly with your patients, then Ben has an Explain Pain course coming up in December on the 4th and 5th. It is online, 2 days. Ben is an amazing teacher. I'm sure that you've had a sense of that today. We get amazing feedback from all of his courses. So Ben, could you just briefly tell us a little bit about what people might expect if they chose to attend that 2 day course with you in December?
Um, we think about why pain is a problem. We think about what is education. I suppose there's three bits to it, Joe. There's the sciencey stuff, and this is often why people come.
Yeah.
What's the science of how we experience stuff? So on my course, I tend to almost start from the big picture. We work inwards. How do we
Mm.
experience stuff? What do we know about consciousness? How do we have this experience that is pain? What's the brain's role in pain, and how might we articulate that to patients without suggesting it's all in their head? That's probably the biggest trap to stay out of. We come down into the spinal cord, we think about the science of central sensitization. We go out into the periphery, we think about peripheral neuropathic causes and nociceptive causes. What is it that's going on in your tissues that generates a nociceptive message? That's the science. And then there's the education approach, and these things are woven through it.
Yeah.
I can't tell somebody that the ideas they've got about pain are wrong, because that's simply going to start a clash. But I want to understand, help clinicians understand, how do we understand about our patients? What are their views, understandings, beliefs, ideas, and how do we then shift it a little bit towards an understanding of pain that might be more useful? And by understanding, I suppose what we're really trying to do is reduce fear of pain,
Mm.
reduce tissue focus, only tissue focus, increase people's understanding of some of the stuff we've talked about today. But then also, how do we get people to embrace that wider package of treatment? Maybe we all do exercise, maybe we're loads of manual therapists, but what's the role for relaxation meditation? What's the role for
Mm.
psychotherapy, talking therapy? What's the role for linking with social workers and social support, charity sector? So it's that shift. How do we shift that person, help them shift towards a deeper understanding, so they understand that they've got lots of tools to apply?
Yeah. Amazing. Thank you, Ben. Thank you so much for sharing your expertise with us today. And thank you, everybody, for
Pleasure.
joining us live. We love to connect with everybody in the audience. It's absolutely superb. So we hope you found it valuable. Thank you for your questions. I am sorry we didn't get to all of them, but please do join us again in, I think, about 3 weeks' time, when Ben's going to be doing another live. We look forward to seeing you in the future, and do come back again. It's been absolutely great. Thank you so much. Take
So,
care,
thank you
everybody.
everybody for joining. Take care.
Enjoy the rest of your day.